immunological differences between open and laparoscopic radical prostatectomy. So our colleague from National Cancer Institute, Bosas, please, you can start.
Hello, my name is Bosas. I'm a urologist from National Cancer Institute. Here I would like to present my theme, immunological differences between open and laparoscopic radical prostatectomies. Paradoxically, biochemical recurrence might be spotted faster in postoperative follow-up in cases where Gleason score, operative margins, and extraprostatic extension looks quite satisfactory. This phenomenon might be attributable to an immunological rearrangements induced by tumor excision. Surgery-induced perturbations might be highly dependent on the method of prostatectomy applied. Surgery-induced factors you can see in blue arrows. Before operation, even in low stages, cancer cells circulating in the blood. It is a fact extensively reported that open prostatectomy results in significant increase in number of circulating tumor cells during the surgical procedure. Interestingly, application of the laparoscopic prostatectomy method did not reveal an increase of circulating tumor cells. Another factor, another blue arrow, is immunosuppression. Myeloid-derived suppressor cells, or MDSC, and T regulatory cells, or Treg, sometimes even B cells, or BREG, or CD90 plus, CD5 plus, are major components of immunosuppressive tumor microenvironment. Also, if during operation for anesthesia you are using sevoflurane, you have more immunosuppression than in case of if you are using propofol. And of course, if you have bigger surgery and bigger wound, then you have bigger surgery stress, and that causes more immunosuppression. Next blue arrow is hypercoagulation. Around cancer cells, due to hypercoagulation, form strombs, and immune system cannot recognize that cancer cells. This helps for cancer cells to grow and spread. And last, inflammatory response. During operation, you have prostaglandins E2, catecholamines, for example, epinephrine and norepinephrine, they deactivating natural killers and cytotoxic lymphocytes. These all factors can influence immune restoration after tumor excision. We hypothesized that less invasive surgical technique might result in less harmful postoperative rearrangements in inflammatory, coagulative, and immune surveillance system. The aim of the study was to assess predictive factors of the immune system for tumor recurrence after open and laparoscopic prostatectomies. Objectives was to compare the dynamic of changes of immunological components following these two procedures, to assess the association between these changes and clinical data, that means Gleason score, stage, margin, and to assess the relationship between immunological status and the risk of biochemical recurrence. Scientific novelty of the study and implementation into clinical practice. An innovative drug elimination rate algorithm has been adopted to fine-tune specific postoperative PCA management. A website option has been offered for clinicians and patients in need of rapid data processing during the follow-up postoperative period. Immunosite-sparing anesthesia, that means a total intravenous anesthesia with propofol, and epidural anesthesia or local subfascial anesthesia was used, and analgesia deprived of opiate administration also was used. We revealed specific immunological signatures associated with LRP or ORP, as well as patient risk groups. Immunophenotype rearrangements combined with EPSA appear to be prognosticator, indicating the likelihood of biochemical recurrence. Our statements that the cellular immunoprofile associated with the specific surgical technique applied, LRP or ORP, the specific immunoprofile pattern was also associated with prostate cancer risk group. Biochemical recurrence, LRP or ORP, can be predicted based on the preoperative profile or immunophenotype and the specific rate of PSA change. Methods. A total 108 patients with T2 and T3 stages was evaluated. We used total intravenous anesthesia with propofol, as I said, without opiate administration. Radical prostatectomy we performed in open and laparoscopical manner. We did immunophenotypic before surgery, 1 month following, and 3 months following RP. We recorded clinical and pathological data. To fine-tune specific postoperative PSA management, EPSA has been adopted. Patients were stratified into high and very high risk group and into intermediate or low risk group. Progression-free survival was monitored. In National Cancer Institute, we performing enough operations to ensure quality of operations to compare these two methods. The list of specific immunocytes evaluated in the study is presented in this slide. Results. Both groups of surgical technique applied were identical as judged by clinical pathological characteristics. You can see here. Objective 1, to assess and compare the dynamical changes of immunological components. Here, the specific changes of subsets in response to radical prostatectomy performed by open or laparoscopic technique are presented. Statistically significant changes are marked in red. The minimal invasive technique, marked as red line, appears to be advantageous in restoring B cell count. Interim conclusions of first objective. Myeloid-derived suppressor cells increase in the postoperative period in the open radical prostatectomy group and did not reveal an upregulation in the LRP group. The LRP group revealed postoperative restoration of B cells faster than in ORP group. Cytotoxic lymphocytes increase in the postoperative period in the LRP group and did not reveal an upregulation in the ORP group. Objective 2, to assess the association between immunological changes and clinical data. In order to assess the relationship between changes and number of immune cells and clinical data of prostate cancer, we stratified clinical data according to risk groups, as you can see here. A problem of exact PCA timing for patients follow up in postoperative period was evident. In case patient planned for PCR testing arrived with slight deviation from the appointment date, say 1 month, then just few days of postponement might have played a significant role in PCA deviation, since half-lifetime of PCA decline in the range of 2-3 days. The result of PCA in scenario can vary considerably, as we can see in the top figure 1. Because in that period, PCA is decreasing quite quickly. Therefore, we have introduced an ePCA to adjust this. In addition, when the PCA values are logarithmatized, feature 2, we can see that for some patients PCA decreases rapidly, while for others it tends to bounce and starts to rise again. This is evident when patients are divided into risk groups. Low risk group figure A and high risk group figure B. Here changes of subsets in their relationship to risk groups are presented. Statistically significant changes are presented in red. Interim conclusions of second objective. High-risk group increase MDSC, no changes on cytotoxic lymphocytes. Low-risk group increase in cytotoxic lymphocytes, natural killers, and absence of MDC increase. Objective 3, to assess the relationship between immunological status and the risk of biochemical recurrence. After calculating Kaplan-Meier survival curves of biochemical recurrence-free survival of postoperative patients, we found the statistically significant difference between the risk groups, stages, and Gleason scores. There was no statistically significant difference between operating methods. Case-by-case statistical analysis of ePCA and all immunous populations revealed 2 interesting results. The combination of preoperative T regulatory cells with ePCA resulted in an increase of predictive significance of BCR after open radical prostatectomy. And the combination of preoperative CD4, CD8 plus CD69 plus ratio with ePCA resulted in an increase of predictive significance of BCR after laparoscopic radical prostatectomy. And conclusions. The LRP appeared to be advantageous in sparing postoperative immunosurveillance, increased number of cytotoxic lymphocytes, reduced B lymphocyte, and absence of upregulation of myeloid-derived suppressor cells. Upon excision of PCA, two patterns of immunocyte rearrangements were observed. A complete restoration of T cells, natural killers, cytotoxic lymphocytes, whereas MDSC did not reveal an upregulation trend follow RP. This pattern was attributable to the laparoscopic method and to the low-risk group patients. And second, an absence of cytotoxic lymphocytes increase as well as MDC increase in the post-operative period. This pattern response was observed in patients undergoing the open surgery and patients in the high-risk group. The combined EPCA plus preoperative CD4 FOX3P, that's mean Treg, value appeared to be the best predictor of biochemical recurrence in open radical prostatectomies operated patients, whereas the preoperative CD4 plus CD8 plus CD69 plus ratio combined with EPCA exhibited a prognostic priority on the LRP procedure was applied. Thank you.
Thank you for the presentation. You hear doctor's PhD job, so very difficult topic. Thank you. Final steps left, so good luck for you.
Thank you.